Good morning, respected teacher. In my seminar on surgical approach to kidney and step by step radical and partial nephrectomy.
Go ahead. Yes, go ahead.
Outline of the yes, outline of the seminar is applied anatomy of the kidney, surgical approach to kidney, radical nephrectomy, lymph node dissection, partial nephrectomy, or nephron sparing surgery. Anatomy of the kidney. Kidney are paired, ovoid, or bean-shaped retroperitoneal organ situated in the paravertebral region. Each kidney measures 10 to 12 centimeter in length, 5 to 7.5 centimeter in width, and 2.5 to 3 centimeter thickness. The weight of kidney is 125 to 170, and 10 to 15 grams smaller in females. Well vascularized, receiving the 25% of the cardiac output. Relation of the kidney to the right side kidney related upper pool suprarenal gland, right suprarenal gland, and outer surface liver, medial antesurface duodenum, and outer lower surface is related to colon, and outer medial antesurface is related to coils of jejunum. The left kidney is related to the left kidney related to upper pool left suprarenal gland, the anterior outer surface related to spleen, and medial antesurface stomach and pancreas, and medial antesurface left descending colon and coils of jejunum. The renal vasculature, the renal artery divided anterior and posterior division. Anterior division supply 2/3 of the kidney, and posterior division 1/3. The anterior division further divided apical and upper, medial, and lower segmental artery, and posterior segmental artery. Renal vasculature. The veins anastomose freely throughout the kidney. Anastomose variation in the renal artery vasculature 55 to 40%. CT angiogram, CD construction is the gold standard to see the vasculature of the kidney. Accessory renal artery 25 to 28%. Sole arterial supply to a specific portion of the kidney. Lymphatic drainage. The lymphatic drainage of right kidney is precaval, paracaval, retrocaval, and intra-aortocaval lymph node, and the lymphatic drainage of left kidney, pre-aortic, para-aortic, and retro-aortic lymph node. Surgical approach and incision. The wide incision or proper exposure is the hallmark of the surgery, and it depends on the various factors like tumor size, tumor location, location of the affected kidney, patient habitus, or patient medical or surgical history, having the kyphosis, low pulmonary reserve, low cardiac reserve, or clinical preference. Various approach, anterior approach, in anterior approach, midline transperitoneal, subcostal, bilateral subcostal, transverse abdominal, paramedian, and modified thoracoabdominal approach is given. The flank approach. In flank approach, subcostal, supracostal, and transcostal approach is used due to depend on the tumor size, tumor location. These are the diagrams showing midline, entry approach, subcostal, chevron, paramedian, transverse abdominis, and thoracoabdominal incision. And second diagram showing subcostal, supracostal, and transcostal approach for the kidney. Flank incision, transcostal or supracostal or subcostal incision given through 10th or 12th rib, excised and preserved, cut latissimus dorsi, external oblique and internal oblique, and split the transverse abdominis muscle. Entire procedure extrapleural and extraperitoneal, ideal for partial nephrectomy, simple nephrectomy, or tumor on the lower pole, difficult upper pole tumor or IVC assessed by the flank incision. Thoracoabdominal incision, excellent exposure of large tumor as well as upper pole tumor, in particular on the left. Afford easy access to the adrenal gland and thoracic cavity, made over the bed of the 10th, 9th, 8th, 9th, 10th ribs, depending on tumor surgeon factor. Pleural cavity entered, diaphragm divided in direction of the muscle fiber. Diaphragm opened from the thoracic cavity and posterior to anterior muscle dividing. Medially extended down the midline or across the midline. Radical nephrectomy indication. The various indication of radical nephrectomy depend on the renal tumor occurring in a non-functioning kidney. Patient would not tolerate complication of partial nephrectomy. Large tumor, T2 or above, replacing most of the kidney. Central renal tumor in a patient with normal contralateral kidney. And tumor characteristic, numerous tumor involving most of the parenchyma, multifocal tumor. Tumor associated with regional lymphadenopathy, tumor associated with renal vein thrombus or IVC thrombus, and tumor associated with metastasis. Difficult partial nephrectomy requiring intraoperative conversion and patient preference. Operative step of radical nephrectomy. For radical nephrectomy, patient in the general anesthesia and Foley's catheter is inserted, and the proper position is given, the supine position. The pressure point is well padded and table extended at the patient's waist between the iliac crest and costal margin. Incision, subcostal incision, flank position, position, flank position, and incision, subcostal incision. Approach to right kidney by dividing abdominal wall, incising along taut line of right colon, continuing up and around the hepatic flexure, and colon mobilized medially. Taut line is the fusion of the anterior posterior layer of the aorta fascia with posterior peritoneum, and from the hepatic flexure it excites to the iliac vessel. After colonic mobilization, the second portion of duodenum is encountered, and duodenum mobilized medially by the Kocher maneuver. Kocher maneuver is performed, and duodenum along with pancreas dissected of the IVC and aorta, and the anti-surface of the IVC and anti-surface of the aorta fascia is exposed. Open then encounter anti-surface of IVC and aorta fascia. Approach to left kidney. Towards the left kidney, the taut line is excited from the splenic fracture to the iliac vessel. Splenocolic ligament taken down and spleen immobilized, cephalite or cranially. Spleen and pancreatic tail mobilized medially of the aorta fascia. If at the lower pole, ureter is identified and encircled with a vessel loop. Gonadal vein is ligated and divided routinely on the left and when necessary on the right. The plane between mesentery of colon and serosa fascia is developed. A avascular plane, fibroalveolar plane between the mesocolon and the anti-surface of the aorta fascia is dissected, and renal hilum is exposed. At the renal hilum, the gently dissection done and exposed the renal vein and posterocranially the renal artery. If the renal artery is difficult to expose at the renal hilum, reach the lower pole and lift the ureter, and by the posterior approach, identify the renal artery. Ligate and divide the ureter before attempting to expose the renal hilum to allow for mobilization and upward displacement of the lower pole of the kidney. Prior to control renal hilum, gyrotophasia may be initially mobilized posteriorly and superiorly, or this can follow ligation division of the renal vessel. Which vessel first? First ligate the renal vein, and after ligation of the renal vein, supply to renal artery ligation. Sorry, which vessel first? Preliminary renal artery ligation remain an accepted practice. After ligation of the renal artery, the supply to kidney and tumor is decreased, and we will feasible to assess the tumor thrombus in the renal vein. Whole pedicle clamp technique may be utilized to control the hilar vessel. When the separate ligation is not possible, the whole pedicle is ligated. Chance of arteriovenous fistula may be associated with the en bloc ligation of whole renal pedicle. Ipsilateral adrenalectomy. Adrenalectomy is done when the involvement of the adrenal or tumor at upper pole and large side tumor and tumor having lymphadenopathy or venous thrombosis. Location of the tumor in the upper portion of the kidney immediately adjacent to the adrenal gland is another relative indication for adrenalectomy. Pre of CT or MRI can miss 25 of adrenal mass. So preoperative imaging like CT or MRI miss 25 of adrenal metastasis. So during intraoperative, the visual access of the adrenal gland and palpation of the adrenal gland is necessary. Routine removal of the adrenal gland is not recommended for low stage tumor without any sign of adrenal involvement clinically or by cross-sectional imaging. Lymph node dissection. The lymph node dissection is done when the lymph node is involved. So, the right side tumor, the lymph node dissection done from the crus of diaphragm to the bifurcation, and left side from crus of diaphragm to the common line. These are the diagrams showing lymph node dissection, interaortocaval nodes, and second diagram showing crus of diaphragm and bifurcation of the aorta, and all node, lymph node present and fat and fascia present in the region is dissected. Lymph node involvement in RCC is to be associated with a poor prognosis. 5-year survivability is 35%. Minimum 15 nodes are required for examination. If not clinically and radiographically suspected, incidence of lymph node involvement is low, 4 to 14%. Regional lymphadenopathy is frequently due to inflammatory change and not RCC metastasis. The more chance of it is due to inflammatory. Lymph node dissection guidelines. European Association EU recommend considering an external lymphadenopathy in patient with adverse clinical feature and in the presence of clinical palpable lymph node or lymph node present on the imaging. The American Urological Association and National Comprehensive NCCN guideline recommend not to perform routine lymph node dissection. Complication of radical nephrectomy. Complication is the deviation from the normal intraoperative of the or postoperative course. In intraoperative, it is bleeding and injury to great vessel, injury to vasculature of the gut, injury to bowel. In postoperative, bleeding also occur, infection, and pulmonary complications, CKD, and cardiovascular event and increased mortality rates. हाँ. The partial nephrectomy or nephron sparing surgery, it is paradigm to shift from the radical nephrectomy to partial nephrectomy due to excessive use of imaging, CT MRI, or use of the minimal invasive surgery. Increased utilization and availability of the CT MRI result in more renal masses being identified. Concomitant stage migration, renal masses identified at early stage. Incidental renal mass 3 to 13% to 48 and 66% in 2000. Nephron smearing surgery entailed complete local rejection of the tumor while leaving the largest possible amount of the normal functioning parenchyma in the involved kidney. Partial nephrectomy indication, tumor in a solitary kidney, small size tumor, bilateral renal tumor, multifocal, and familial tumor, tumor in bilateral kidney, severely compromised renal function, threaten of future loss of renal function, जैसे comorbidity, like comorbidity, hypertension, diabetes. A small amenable renal tumor less than 7 centimeter with normal contralateral kidney. Location more than tumor size is the critical factor. The contraindication of the partial nephrectomy, if the cold ischemia or warm ischemia time is more or less than 20% of global nephron mass is retained. So there is chance of hyperfiltration or increase creatinine. Cancer-related issue, diffuse encasement of renal pedicle by tumor, diffuse invasion of central collecting system, tumor thrombus involving major renal vein, adjacent organ invasion, or regional lymphadenopathy. If these factor is present, the partial nephrectomy is contraindicated. Type of partial nephrectomy, there is type of partial nephrectomy present. Enucleation, only tumor is extracted, and phase rejection when the tumor and a rim of normal parenchyma of the renal is extracted. Segmental nephrectomy, polar nephrectomy, hemi and vein surgery. Before the partial nephrectomy, the renal nephrometry score of the tumor is necessary to see the complexity of the tumor, and the 3D construction of the renal vasculature and the collecting system is also necessary. The renal nephrometry score, the renal radius of the tumor, if tumor is less than 4 centimeter or 4 to 7 or more than 7 centimeter, and exophytic or endophytic. If more than 50% tumor is exophytic or less than 50% exophytic or totally endophytic. And near to collecting system, if more than 7 mm, 4 to 7 mm or less than 4 mm. Anterior or posterior tumor, and the location of the tumor to polar line. When the tumor is more than 50% tumor is above the upper or below the lower polar line. When the less than 50% tumor above the polar line or below polar line, and tumor entirely within the polar lines. Renal nephrometry score satisfy complexity of the tumor. If the score is 4 to 6 is mild, and 7 to 9 moderate, and 10 to 12 it is high complexity. Add in the treatment, decision making, and counseling. Predict success of partial nephrectomy. Decrease in the tumor proximity to the central large structure was the main parameter that reduced the nephrometry score and decreased the surgical complexity. Risk of post-operative complication and functional and oncological outcomes. Preoperative principle. Before partial nephrectomy, preoperative defining the renal vasculature is more important and defined by CT angiography or 3D CT. Renal function estimation. Optimal renal perfusion approximately 200 ml per hour crystalloid overnight is given, and hydration with a 1 liter crystalloid bolus over an hour prior to scheduled operation. Prepare iceless saline for intraoperative renal cooling in anticipation of the arterial occlusion or regional hypothermia. Adequate renal hypothermia, core renal temperature 23 degrees Celsius, take at least 15 minutes to achieve the kidney is packed with iceless. Intraoperative principle, kidney approached by extraperitoneal flank incision or transferred to peritoneal by midline or subcostal or thoracoabdominal incision. Dissect the kidney free of the perineal fluid. Palpebral tumor should remain fat cover. In partial nephrectomy, the fat on the tumor is not dissected, and the fat present on the renal parenchyma around the tumor is dissected. Early vasculature control is the key for minimizing blood loss and for prompting renal hypothermia. Leave surrounding perivascular advential layer intact to serve as a cushion. Inspect the entire remaining tissue. Administer intravenous mannitol and furosemide 15 minutes before arterial clamping. Mannitol, osmotic diuretic, free radical scavenger, minimize ischemic insult and acute tubular necrosis. Decrease intracellular swelling, promote diuresis, and minimize the sequelae of revascularization, injury, cell swelling, and release of free radicals. Isolate renal pedicles sufficiently to allow safe application of a vascular clamp. In partial nephrectomy, generally we apply clamp on the renal artery, and if the renal artery clamping is difficult, we applied a bulldog clamp on the pedicle. Lower the surface and core renal temperature to minimize ischemic damage to the kidney. Cross-section analysis of the rejection margin is important at Jangid. Closure of the collection system is mandatory to prevent the fistula formation or urinary leak. Partial nephrectomy can be performed with warm, cold, and no ischemia time. Warm ischemia time should not exceed 20 to 25 minutes. 5% increase in risk if increased risk for acute renal failure for every additional minute. Cold ischemia time should be preferred if partial nephrectomy takes more than 20 minutes. Surface cooling to achieve medullary temperature of 15 to 20 degrees Celsius by cold saline slush. Up to 60 to 70 minutes ischemia time tolerated. Functional recovery from ischemic damage occur in few hours after 20 minutes, few days after 30 minutes, and several weeks after 60 minutes of the therapy. Avoid intermittent renal arterial occlusion, potential arterial vasospasm, and post-op renal damage. Zero ischemia time. Selective clamping. When we clamp the selective artery of the tumor, and there is no ischemia of the remaining renal parenchyma, or if the tumor is small size, we don't clamp the renal pedicle and excise the tumor without clamping. Prepare bolster by rolling nuke it around 1 into 5 centimeter piece of gel foam and tying the ends with a 40 cycle. Prepare placate by folding nuke it into a double layer 2 into 5 centimeter rectangle. Prefer Surgicel because it is absorbable, does not shrink when wet, and has tremendous tensile strength. Use of flow seal and perinephric thread is also used. Advantage of the temporary renal artery occlusion: decrease intraoperative bleeding, decrease tissue turgor, allow for palpation of the kidney for non-obvious intraparenchymal lesions that are not readily identifiable when the kidney is perfused, allow for better dissection of tumor, especially located tumor, and assessment of the extent of involvement of contiguous intrarenal structure. Advantage of intraoperative ultrasound. Evaluation of the modality when preoperative imaging strategies are equivocal. Intraoperative ultrasound is used to locate the size of tumor and depth of the tumor. Operative step, partial nephrectomy. Enucleation used for small exophytic lesion less than 3 cm with a rim of normal parenchyma. Renal occlusion is not necessary except in bleeding cases. Explore the capsule with electrocautery. Identify plain outside pseudocapsule of tumor and develop XI with the combination of blunt and sharp dissection. Dissection from tumor crater bed. Suture ligate bleeding vessel with 40 or 50 abdominal monofilament suture and repair collecting system with 40 abdominal monofilament suture. And close the defect with a horizontal mattress suture using a 20 abdominal suture. This is the photograph showing enucleation of the tumor. Operative step for wedge resection of the tumor during partial nephrectomy, temporary arterial occlusion, hypothermia, labral hydration, occlude the renal artery with vascular bulldog, occlusion of the renal vein, help in retrograde perfusion. When the renal vein is not occluded, help in retrograde perfusion of the kidney and might minimize the chance of post-op acute tubular necrosis. Applied ice saline slush and cool the kidney to allow for adequate core renal hypothermia. Circumferentially incision and rejection with adequate margin of 5 to 10 mm. Controlling bleeding vessel with 4050 suture is or with electrocautery and close the collecting system with 4050 abdominal suture. Segmental nephrectomy or polar. When the tumor is present on the upper or lower pole, segmental or polar partial nephrectomy done, renal hyrum dissected and segmental arterial isolation done and isolated segmental arteries clamped, tumor excised. Mark the line of ischemia with electrocautery, ligate the apical basal segmental artery and then clamp the renal pedicle and block with the vascular clamp. Place a plastic bag or sheet around the kidney and fill it with ice slush. By blunt dissection, excise the pole of the kidney, control bleeding, close the collecting system. If the collecting system is really large, insert a guide wire into a defect and guide it into the ureter and bladder. Operative step of nephrectomy used to reject non-functional parenchyma associated with upper pole of a duplex collecting system, polar urothelial carcinoma, and large polar tumor exceeding the bounds of segmental pole nephrectomy. And double G stent prior to incision is done. Renal hyrum dissected and major branches identification is done. Clamp the renal artery and place a plastic sheet around the kidney and cool it with ice slush. Explore the renal capsule with electrocautery, staying as far from the main renal artery and vein as possible. Use blunt and sharp dissection to remove the tumor from the kidney. Large vessel and collection system will be encountered and clamped and ligate these prior to dividing them, like in phase resection. Operative steps, partial nephrectomy, bench surgery. When the most perceivable indication is the presence of a large central tumor in a solitary kidney, large central mass encroaching on the renal pedicle, large central renal pelvic tumor, or multiple subcortical neoplasm. Standard radical nephrectomy with particular attention to preserving the maximum length on the renal artery and vein. After removal, perfuse the kidney with urocolin solution, flushing the kidney solution continue until it is cooled at the renal effluent is clear. Resect the tumor, frozen section analysis of the margin, perform reconstruction, infusion of the artery and veins with urocolins, Reimplant the requesting kidney in the contralateral iliac fossa with the standard renal transplantation technique. A nephrectomy surgery advantage: preservation of renal function, preservation of renal parenchyma in case of contralateral recurrence, incidence of contralateral recurrence 2 to 4%, nephrectomy disadvantage: tumor recurrence in the preserved kidney up to 10% as with tumor multiplicity rather than positive margin. Positive margin also occur up to 7% of the tumor. Complication: partial nephrectomy complication, hemorrhage, intraoperative and postoperative hemorrhage. Smoking and high ASA score increase the frequency of bleeding. Maximum radiological management, radiological angioembolization or nephrectomy. Urinary leak and fistula. When the collecting system is open, urinary leak or urinary fistula occur within 7 days. So the drain in partial nephrectomy kept for 7 to 10 days. Urinary fistula is confirmed by output creatinine investigation or endocarmine dye and managed by conservative management for 4 to 6 weeks. Other complication is infection and hyperinfiltration injury. Focal segmental glomerulosclerosis with proteinuria and progressive renal failure occur. Renal artery thrombosis occur and acute renal failure. Laparoscopic and robotic approach. The indication for laparoscopic and robotic approach is same as open approach. Advantage is the minimal invasive, less blood loss, less post-operative pain, early recovery, and short hospital stay. This is the port position for robotic nephrectomy. Complication: step for robotic or left nephrectomy, patient selection and port position, mobilization of the colon, dissection of the renal hilum, after dissection, clamping in partial or complication associated with laparoscopic or robotic nephrectomy, assess related problems. Bleeding due to solid organ injury or blood vessel injury, bowel injury, abdominal wall hematoma, and epigastric vessel injury, hemorrhage, pneumonia, pulmonary embolus, unrecaused bowel injury, and incisional hernia after intact specimen removal. This is the video of laparoscopic right partial nephrectomy. Tumor of the upper pole of right kidney and nephrometry score is 8A. This will be inside the hepatic flexure of the colon. After hepatic flexure mobilization, the liver is related and tumor is identified, and duodenum is medially mobilized.
Thank you. Thank you, Gajendra. And so, again, if you have any queries, please let me know. I'll just briefly summarize. We all know radical and partial nephrectomy is the the definitive treatment approach for localized RCC, right? In the beginning, definitely, most of these patients of RCC, we used to do radical nephrectomy. Though partial nephrectomy, the first partial nephrectomy was done by Vincent Journey in 1887. The patient had an angiosarcoma of the kidney. But then, for decades, partial nephrectomy was not done, and fearing that any patient of renal carcinoma must be having a little small micrometastasis. So, or it may be involving the other parts of the kidney also. So it was Wormington in 1950 when he said that yes, partial nephrectomy can be done in selected cases. That was in 1950 with a 1 centimeter margin. And then we started doing partial nephrectomy in selected cases like solitary kidneys, bilateral tumors, patients with CKD, etc. Then in 1970, again, people started questioning that why not do partial nephrectomy even with a contralateral normal kidney. And then over the decades, it became clear that yes, you can do partial nephrectomy even in patients who have a contralateral normal kidney. So in the year 2015, it came in the guidelines of the Campbell's Urology also that partial nephrectomy is the treatment approach for appropriately selected patients, even in patients who have a normal contralateral kidney. Now we know that partial nephrectomy has advantage over radical nephrectomy in the sense that it not only spares the nephrons, it will improve, it is a better GFR post-operatively than having a radical nephrectomy. And the most importantly, the patients have less non-cancer related deaths. The overall mortality in these patients due to non-cancer, due to non-RCC related is less, so that the overall survival after partial nephrectomy is seen to be better than radical nephrectomy. And this is probably due to the GFR related comorbidities and the cardiovascular comorbidities that happen after a radical nephrectomy. So we all know partial nephrectomy now is the standard treatment for all tumors of T1A, that is less than 4 centimeter lesions, most of the tumors. But now this has also extended to T1B and even T2 lesions. So many of the even T2 tumors, we can do a partial nephrectomy. Now again, this will depend upon the complexity of the tumor, the nephrometry score, and the expertise of the surgeon. We all know many of these tumors, particularly patients as we have already described, that solitary kidney, bilateral tumors, and patients who have part of the syndromes, VHL, papillary carcinoma, which is again might be bilateral, and they tend to develop another tumor fast. So in these patients, definitely partial nephrectomy should be the standard approach, besides what we have said. And the complications, it has been seen the time to recurrence, the cancer-related mortality, etc. All these have been found to be similar in both partial and radical nephrectomy. Though there is a slightly higher complication rate in partial nephrectomy, post-operative morbidity may be slightly higher, but the overall mortality due to surgery is same. So partial nephrectomy is the treatment approach in wherever it is technically feasible in even patients who have a contralateral normal kidney. Radical nephrectomy, we all know, this was described by Robson in 1963, how to do it. We all are doing radical nephrectomy. Previously, we used to remove the adrenal gland also. Now we don't remove the adrenal gland, only in case if it is an upper pole tumor or it is infiltrating into the adrenal gland. Otherwise, the lymphadenectomy, we remove the hilar lymph nodes, definitely. But lymphadenectomy of the retroperitoneal lymph nodes is not indicated, because if it is metastasized into the lymph nodes retroperitoneal, it is supposed to be the radical nephrectomy should be done in patients if the tumor is involving the adrenal tumor, adrenal gland, or the renal vein, or it is involving the perinephric fat. Then we should not do a partial nephrectomy. So this was in a nutshell about the treatment approach to a localized RCC by either partial nephrectomy and radical nephrectomy. We all know that with the minimally invasive approaches, both laparoscopic and robotic, we have been doing most of these partial nephrectomies by either lap or robotic, which has made the surgery even simpler. And the morbidity, post-operative morbidity, and the complications much less than the open partial nephrectomy. And even radical nephrectomy can be done by lap or robotic, which again has less morbidity in the post-operative period. So this was in a nutshell. If anybody has any question, or the participants who have joined us today, if they have any question, please let me know. Put it in your chat box or just raise your hand. If not, then I would request Dr. Dharmendra, would you just... so we will wrap up the session today. And I thank you once again, all the residents and the faculty members, and all those who might have joined us today. Thank you and have a good day.